Our final speaker is our co-moderator, Dr. John Paige. Most of you know John. John has dedicated his life to surgical education. He's an associate professor in Louisiana State University and the director of their simulation lab. He's recently authored a book in simulation radiology, which is a first of its kind. And he's going to talk about what are the next frontiers of simulation in education in surgery. John, thank you.
Thank you very much. It's my pleasure to talk a little bit today about surgical simulation in 2020. This is my funding support currently and disclosures. As was stated, I'm a co-editor for simulation radiology, and I do have funding research from ACEL and then Intuitive for the FRS validation trial. So what's the goal of my talk today? My goal is to promote the incorporation of simulation-based techniques and training into surgical care and improvement, and to improve patient safety and outcomes through that process. I have three main objectives. One, I want to review first key features of nomenclature and concepts related to simulation-based training and education, and then I want to compare and contrast different applications of simulation-based training in current use in surgical care, and then I'm going to try to sketch how simulation-based techniques might be used in the near future to enhance surgical education, training, and patient care. But first, this is the last day at SAGES, my last talk. So I have a little riddle for everybody, a Nashville riddle. I have several people up here. I have Loki, the god of mischief in Norse mythology. Brian Glover, he's a songwriter and singer. And then Abraham Maslow, who is a leading psychologist. And I ask, what do you think each of these people have in common? What might be these people have in common? You can shout out an answer. I'll give you a second. I'm sorry? Self-actualization, very good. Maslow was the founder of that concept. But it's hammers. So Loki in Norse mythology got Thor's hammer. And Brian Glover wrote this song, when you're holding the hammer, everything's a nail, which Maslow was accredited with that expression. And so you might say that, you might think I'm holding a hammer here when I'm talking about simulation. So let's talk a little bit about key terms and concepts in simulation. First, just to go back, it comes from Latin, simulatio and simulare, and it means to imitate it for purposes of training. That's the first use, how we use it now, simulation. That was in 1966. I think the best definition I've come across to kind of define what simulation is in healthcare education is this one by Pamela Andreotti and her colleagues in this article, which they defined it as instruction that makes use of facsimiles of clinical context wherein learners interact to acquire knowledge, skills, and effective elements that will ultimately transfer to the real clinical context. And that's the key. We want to be able to create simulations that allow clinicians to transfer whatever they learn, or learners to transfer whatever they get out of it to the actual clinical context to improve quality and safety and outcomes. Just some key terms regarding fidelity and what is fidelity. There are various ways you can break up fidelity in simulation because these terms are thrown around: low fidelity, high fidelity. And my favorite of these, there various authors have kind of defined it. And since I'm a simple country surgeon, I kind of put it into layman's terms, which I think is you get a real life look, and that's what would be defined as kind of physical or equipment fidelity by various authors. You get real life action, which would be the environment fidelity. That is, it's going to act like it is in real life. And then finally, you get the real life feel, which we call that suspension of disbelief or psychological. And I like the term emotional fidelity as well, because you get invested in it. We saw that earlier in the earlier talk with the avatar, which is not necessarily as realistic as possible, but the learner is drawn in and believes in it, so to speak. But the thing I want you all to remember I was talking about the god of mischief here. And so the god of mischief created Thor's hammer, as I said. So the question is, what's a hammer? What is a hammer? how would we define a hammer? It's a tool, right? It's a tool. And just like this is the oldest operating medieval clock in the world, I think, at Salisbury Cathedral, and that is the atomic clock. Very different, but they're both tools, right, we've created. And the thing to think about is simulation is a tool. It's not a curriculum, and it's very important to keep that in mind when you're developing your curricula. It's not like, and that's part of the issue we've had with simulation in healthcare with the virtual reality. They create these devices and they say, okay, how are we going to use it? As opposed to creating the curriculum and then, okay, let's use a tool, let's design the tool to do it that way. And there are key features when you're talking about using simulation-based training when you're writing those or creating those curricula. And one of those is you want it within an objectives-based curricula. You want objectives to your learning, and you want to, as I said, design the objectives and then choose your tools. You want to create proficiency-driven goals, the idea like you're going to train to a certain level and not a certain number of times. And ideally, you want it distributed over time and not all at once. And you want to incorporate Erickson's concept of deliberate practice so you can achieve expertise. The other key point is, I'm going to use Monty Python to help me with this, and the other key point about developing a curriculum using simulation is this. So I'm going to just play this really quickly.
We shall do no such thing. Oh, please. Cut down a tree with a herring. It can't be done. Don't say that word. What word? I cannot tell. The place to say is one of the words the Knights of Ni cannot hear. How can we not say the word if you don't tell us what it is? What is it?
So it's a little hard to hear, but the idea is there's this sacred word that they can't hear. And he's saying, how can I say it if I don't know what it is? And the word is it. And so the question is, it's this idea of, if you don't know what it is, how can you do it? The other one is this one, and I'll bring it together in the next slide. But here's.
Now stand aside, worthy adversary. 'Tis but a scratch. A scratch? Your arm's off. No, it isn't. Well, what's that then? I've heard worse. You liar. Come on, you pansy.
So basically, we have a little communication problem, right? A scratch versus your arms off. And then the idea is like, how can I do it if I don't know what it is? And that's all related to, which I think the key is when you're building a simulation-based training curriculum, is this idea of accurate measurement. So you have to kind of be able to define clearly what you're measuring and to be able to accurately do it. Because if you don't know what it is, how do you know if you're making a difference? And the big problem, especially with healthcare professionals like ourselves, is that we tend to overestimate our abilities. And the problem is the people with the least amount of insight into their ability are the ones who tend to overestimate the most. And so we think we're gods when we're actually not, and we're always asking the mirror, who's the fairest of them all, expecting them to say, yes, we are. So let's talk a little bit about applications currently, or how you can use simulation-based training techniques in the surgical realm or the healthcare realm. And this is a list that divides up kind of the various uses. You could use it for technical skills training and cognitive and et cetera. And I'll talk a little bit more about examples of this in the next few minutes. So one thing you can do is, and it's been definitely proven in the literature, you can use it to train technical skills of surgeons. And it has been demonstrated that you can use what we would call low technology or devices to lead to better OR performance. And you can also use virtual reality devices as well. The other thing you can do is you can have cognitive and technical training. So you can train people into how to use algorithms or how to think about and taking care of patients. And the best example of this is from Northwestern, where they did deliberate practice, they did simulated exercises, and they were able to really increase the retention and the application of ACLS to medicine residents. The other thing we can do is team training, and you can do it both within the actual learning environment or within the actual clinical environment, or you can do it in situ is the term we use that, and I like to be consistent with terms, so I say the other one's ex cura, that is outside of the clinical environment in the sim lab. And this is the one I personally, this is my disclosure too. This is how I like to use it. I like to use it in team training, and we'll talk a little bit about that in a second. The other one is what we call air proofing. I know this is an international audience, but in the United States, does anybody know what this is? Diesel. How do you know it's diesel? It's green, and so it's trying to prevent you from ruining your car engine. But the other thing, what's the other thing about diesel that prevents you from ruining your car engine? It's a bigger nozzle. It's impossible to put it in. And so the idea is this air proofing. And what you can do is you can assess the safety of new teams. So you can train to help new teams be better functioning and more efficient and effective. And then the last thing is what you can use it for, and what's been used in currently is modeling. This idea of you can evaluate surgical workflow and try to improve it through computer-based simulations. So there are lots of uses of it currently that are pretty innovative in my opinion. But what's the future? Okay, so what's the future? What's going to be out there? The title of the talk was 2020, so I only have a 5-year horizon, which I think is good, I guess. So I can't be too crazy, but I might go a little bit far. We have a little better focus on the 5-year horizon than say the 20-year horizon. But in my opinion, what's really important is you really, as the famous quote says, if you don't learn from history, you're doomed to repeat it. So it's really important to kind of get an idea of what's been done and what's happening. And for us, the present at LSU is this kind of team training and other uses of simulation. I'm just going to go really briefly over what we've been doing to just give you an idea, and then I'll kind of keep it home to talk about what 2020 might look like. So we have a concept for our training, for our comprehensive surgical skills training, to go from skills and tasks to procedures and then on to situations. And the idea is to build up, get the basic skills and tasks, go ahead and try to learn it on the procedures, and then incorporate that into situations. So we try to get both the technical and non-technical skills training. For the technical skills training, it's all throughout the curriculum. It's already there in the medical students. This was just a few weeks ago where we had the student orientation, and we're teaching them how to do basic knots and basic suturing. And the idea was to incorporate this into a proficiency-driven curriculum for them. We do the FLS training. We do kind of basic procedure training. And then one of the big things is cadaveric labs, which which is an old mainstay that's been there, but that's a form of simulation as well. So we've tried to create a comprehensive curriculum where you kind of build it. You have various periodic testing. You do various proficiency-based curricula, and then you go ahead on to the next year, and then you might go up to the situations and team training. At LSU, we were fortunate enough to have developed the mobile mock OR, which was a point of care training through a HRSA HRQ grant, and it involved half-day sessions. It was done in the actual learning environment. It focused on all these types of team-based competencies, involved deliberate practice, and was distributed, and we measured a bunch of things for that. What we did is we came home and we applied that at the student level. And so we created basically the same model ex cura within the center using students from various centers. And this is just a sample of what you see. And you can see these are senior students. It's a stab wound to the abdomen, and you can see they're very engaged. We have nurse anesthetist students up top. We have nursing students who are on an OR rotation helping out as scrub techs. So it's a realistic environment. Universally, we talk about teamwork. I'm not as interested in how they handle the stab wound to the iliac vessel, because they're going to learn that on. But what we're really focusing on at this level is teamwork and team training. We expanded this to other areas, allied health students. We expanded it to lower levels. Currently, we're doing our in situ training. We're also doing what we call this transfer training, which is physically transferring the patients, because transfers are a big issue and a big area of potential catastrophic problems. And then the other thing is we're working on trying to test out our new facility before it opens. So we've tried to create this, what I call a comprehensive program for quality and patient safety. And as you can see, there are the various team training programs we've kind of incorporated. We're transitioning over to our new hospital soon. And then what we want to do is create a simulation-based culture, for a simulation-based training culture there. So what's the future? What's the future at LSU? I'll keep it local. This is our facility. It's close. We have just a few more months. They're putting the finishing touches on it. And I'm going to indulge in a little wishful thinking on this, what's the future, and that's what would I want to see at LSU Health in 2020. So basically, if you say you're a medical student in 2020, you're going to graduate in 2024. What I'd love to see are these multiple mini interviews that's been done at McGill and other institutions to identify the students who get the most out of coming to LSU. Then they would hop on the computer, which they do right now, but we would hopefully be able to incorporate those virtual avatars that you've seen, more realistic, and then they would go through these kind of roadmap to learn more. They would do the skills labs that they're doing, but even more in depth, and incorporate the ASC curriculum, that's ACS, ASC, APDS curriculum. They will work on the suturing, then they would go and do team training throughout their upper years, just like they're doing now. And then what we would do is they want to make sure they have their entrustable professional activities. And this is where I think the future is very interesting, is instead of having us rate them, we would crowdsource it. This has been shown to be accurate. And so have them crowdsourced to say, okay, you're ready to go. What about this general surgery resident? Well, same thing, multiple mini interviews to identify the best. We do baseline testing when they come in. We create a modular proficiency-based curriculum, much like Resnick has created for the orthopedic program up in Toronto. Then they would go through various procedures, either virtual reality, et cetera. They pass off. And once they pass off, only then would they go into the operating room to work. And then the other thing is, then we would use 3D to create models for them on which to train. And we would use very challenging cases, et cetera. And that way they would be able to train on real cases, but in a simulated environment. And again, we would crowdsource the skills evaluation as a way to get quick turnaround time and to get them through. We would do the team training all throughout, including all the stuff we're doing. And then we would incorporate the virtual reality, creating the types of scenarios that you saw earlier today. And then in addition, we would use the motion analysis you saw to hopefully help with them to improve their skills and to give them pointers, just like they would do in sports and that sort of thing. And then this would all be within a milestones kind of curriculum and a point where they would go and they'd hit their milestones. We'd use national curricula, so you'd have, you'd incorporate all these, basically the brain power of all these people who've created all these wonderful curricula, and that would be incorporated into it. What about the practicing surgeon? Well, I would see the practicing surgeon like myself. I got a tough case. I would go to the 3D printer, put it in there, and then I would actually physically practice my case the night before. Then I go to the OR and I do my warm-up, practice to get ready and to get set for the operation. I would still go to courses like this and do cadaveric-based, very structured cadaveric-based things to get my new skills. And then we would be doing team training periodically, and part of my MOC would be having to go and do these types of things in order to get through. And then we would do work within the hospital and do facility testing. If there is a root cause problem, we would use simulation to try to identify other potential sources and things like that. So in conclusion, simulation is only a tool, it's not a curriculum, and you can use it throughout the entire professional continuum, and it can impact all aspects of training, education, and patient care, and it's going to continue to be more and more incorporated into everybody's daily practice and be an everyday part of the surgeon's work life. So thank you very much, and we're going to open this up to questions, so if the speakers can come up.
Well, we don't have a lot of time. I think we have a couple of questions online, but if there are any questions, Tony, there was a question for you about the material which that heart valve was made of. So if you want to come here or to this, if there are any other burning questions, please, I just want to thank all our panelists. They're fantastic presentations, and I hope they gave you a glimpse of what's to come in the next few years. Tony?
So the heart valve, from my recollection, was a polymer-based component. It's going for clinical trials. It's not FDA approved yet.
Okay, thank you. Any other questions?
I had a question about the virtual patient and the confidentiality. So, the great thing about being able to just talk is, you talk on the phone and it's not there. But if you're having a conversation, but you're inputting all the your questions, you're filling out all these things. So how do they keep the confidentiality? How do they? Is it erased afterwards? But no, they want to keep that for it. So for the bill, the sim coach, yeah.
Yeah, you can come here or there.
Yeah, we have our own server system that has, an encrypted, whole set of security protocols. When we were building that application, a lot of times people said, what if somebody goes online and is suicidal? And, that's a real concern. But our first and foremost premise was that we wanted it to be a private, confidential thing, so we couldn't have software in there that if somebody had a set of keywords that might indicate I want to end it, all of a sudden the emergency medical team is going to come pounding on the door. We simply have a protocol where if somebody asks those questions or says those things, we pop up, we have the number for a live person call-in line, or the character then says, past a point, I'm only so helpful. I think this is something you should talk to a live person. Here's a number, there's 24-hour service. So things like that. The confidentiality trumps the crisis issue in this case.
Well, thank you very much. For the sake of time, I think we should end this session. I want to again thank our 5 speakers and thank you all of you. I hope you had a great session. Thank you.